Welcome to the second day of the 2021 International Web-Based Neurosurgery Congress. We are grateful for your attendance and support. This has been an amazing experience, and with your support, we hope to keep innovating in the academic field of neurosurgical science. Thanks to all the audience who follows our broadcast. We have the honor today of having Dr. L. Dade Lunsford. Dr. Lunsford is a Lars Lexell and distinguished professor from University of Pittsburgh, Director of the Center of Image Guide Neurosurgery, Associate Director and Chair from the Technology and Innovate Practice Committee. He was responsible for bringing the Gamma knife to the University of Pittsburgh Medical Center, the first center in the United States to offer this state-of-art, minimally invasive for brain surgery. Now, at the 2021 IWBNC, Dr. Lunsford is going to share his lecture, Optimizing Outcomes for Arteriovenous Malformation Radiosurgery. Please write your questions in the Q&A panel. We will read them after the end of the Dr. Lunsford intervention. Dr. Lunsford, welcome and thank you. It's all yours.
Thank you very much for this introduction, and I'm pleased to be among the presenters for information related to this amazing conference with a vast group of important topics for the field of neurosurgery. So we've been using radiosurgery for arteriovenous malformations since 1987. And that was one of the major first usages of the Gamma knife for treatment of what are often complex or deep-seated or clinically very difficult vascular malformations within the brain. So I work with a group of people, some of whom are shown on this slide, who are all colleagues who work together to try to optimize patient outcomes using radiosurgery for AVMs. These are my conflicts of interest. As a stockholder, I work on the Focus Ultrasound Data Safety Monitoring Board, and I was one of the founding members of the International Radiosurgery Society, the Radiosurgery Research Foundation, and I do consulting work for Teladoc. Interestingly, over the years, now more than 3 decades, radiosurgery has become the most common management for brain arteriovenous malformations. And the goal is the same as with any other option. The goal is to get rid of it. And that means that it must be angiographically not visible. Only that really reduces the risks of a hemorrhagic stroke. And we know that based on studies that the average risk of a hemorrhage is about 2 to 5% per year. But there are many factors which influence that risk over time. And I think from an explanation to patient families, one of the more interesting ways to look at this is a cumulative risk, which can be determined by simply subtracting the age of the patient at the time of diagnosis from 105. Therefore, a 40-year-old has a cumulative additional bleed risk of about 65% over the remaining estimated life. We know also that stroke or blood from bleeding from an AVM has a very high risk of death or major neurological complication. And when we look at the decision-making to offer intervention or not, we have to base it on the cumulative risks of the time that it may bleed while you're waiting for this to close off the latency interval, as well as complications of the procedure itself. And we know that other types of radiation delivery techniques, which have been tried over years, do not work. So if we were to take some features that we help to use to predict risks, we can define risks of AVMs as sort of a low-risk type of AVM, one that has a well-defined nidus and more than one draining vein. And veins are probably an important reason that AVMs hemorrhage, because occlusion of draining veins probably leads to a significant risk of stroke. Then there are high-risk AVMs with a diffuse nidus and perhaps only one draining vein. And maybe the first bleeding risk is actually lower than 2 to 5% per year. But once a bleeding event has occurred, whether it's a low-risk or high-risk AVM, the risk of a subsequent hemorrhage almost quadruples. And overall, after a bleed, in our experience, there's about a 10% risk of a rebleed in the first 6 months. So our experience across the use of Gamma knife in over 17,000 patients in this more than 30 years vascular indications are about 11%, with the largest number of these being arteriovenous malformations. We have performed radiosurgery on 1,300 patients over these years, some of whom have more than one procedure. So the total number of procedures is over 1,600. Most of the patients have a single procedure. There are some patients at a period of, let's say, 3 to 5 years, if there is evidence of a residual AVM still present, then we repeat the procedure because the goal, again, is to get rid of it completely. And we have a smaller group of patients who have prospective volume staged AVMs that are quite large and simply too big to be successfully treated using a single procedure, because in order to maintain safety, we would have to reduce the effective dose significantly in that group of patients, which therefore reduces the likelihood of AVM obliteration. The median age is 38 years, although the range ranges from children to older patients. And it's about evenly split between male and female patients. Almost half the patients had had that prior hemorrhage before radiosurgery was performed. And in the initial years, embolization was being used more commonly prior to radiosurgery, and we'll talk a little bit more about that lately. But the current use of embolization has actually declined over the last 5 to 10 years, as we know more about what it may help for, especially prior to microsurgical removal or craniotomy for an AVM. But its role in the radiosurgery is declining. 10% of these patients had already had an operation for either AVM attempted removal or clot removal. Now, the concept of delivery of radiation is to very carefully, using multimodality imaging, define the nest or the nidus of blood vessels. That is, the target lies between the feeding arteries and the draining veins. And we used for the first years only angiography, but the ability over the next 20 years to improve outcomes was greatly enhanced by adding axial imaging. And we prefer MRI scan because it shows us both the target, but also the surrounding brain. It's the most important principle in radiosurgery to know that risk comes not from what the target AVM gets, but what is the dose delivered outside of the target. And therefore, technology that restricts dose to the target and is associated with very rapid fall off of the AVM dose outside of the target is a critical importance to be able to improve obliteration results, but also to reduce risks. It must be, and therefore, a 3D fit at a very sharp fall-off point. And typically in the Gamma knife, that's at a 50 or 60% level. The appropriate dose selection is critical for AVM management. This is based on location and volume, but we've certainly found that over the years, below 18 gray, the response rate falls off so sharply that such doses really are clinically ineffective. And therefore, we're trying to increase the percent of the target that actually receives even a higher dose. And as I will show you from data in our studies, if we can increase the percentage of the AVM target that receives at least 20 gray, we can significantly increase the success rate of obliteration with a single procedure by the time we get out to 3 to 5 years. Now, some people have said, well, it doesn't work for a period of time, and that's true, but actually a certain percentage of the patients are going on from early obliteration and others take longer. So if we look at total closure rate, in 1 year, probably about half the patients properly selected for radiosurgery have obliteration, and by 2 years it increases to 70%, and by 3 years approximately 80%. And once obliteration occurs, then the risk of a hemorrhage essentially goes to close to zero. We have to remember that the goal is to completely get rid of it. And if we look at our overall data on almost 1,000 patients who complete obliteration rates, is 78%, and partial obliteration, meaning that we will need to consider additional treatment, usually repeat radiosurgery, was noted in 22%. And if we look at the dose response curve as we began to work out what doses are clinically effective, we could see that we could improve the response rate at 3 years by getting a minimal margin dose of at least 20 gray. And with lower doses, especially doses at the margin of less than 16 gray delivered to the AVM nidus, then the effect was ineffective, although over time it improved, but the latency interval is simply too long. Well, one of the questions that was asked early on was, does treatment with radiosurgery actually increase the risk of a hemorrhage while you're waiting for the AVM to close? And the answer is, overall, it follows the natural history prediction. Since 50% of the patients had already had a hemorrhage, and that is a known factor to increase the risk of a rebleed rate, it is somewhat elevated in the first 6 months or so, but gradually decreases back to the standard estimated risk for AVM bleeding risk until the time that obliteration occurs. And once it occurs, then the cumulative lifetime risk of a bleed is less than 1%, rather than 1 to 2 to 5% per year, less than 1% over the estimated remaining life of the patient. And we'll talk a little bit about if it's gone, why would it bleed? One is, of course, that if your imaging studies that follow up are incomplete, or in fact fail to recognize the residual AVM, you don't really eliminate the bleeding risk. So follow-up angiography remains extremely important. We know that MRI scan has an excellent correlation with this, and MRI primarily looking at the T2 study and the absence of flow voids. But in patients with contrast delivered can show reactive changes, which may or may not be correlated with eventual demonstration of complete closure by DSA at the end of an appropriate observation interval, typically in the range of 3 years. Well, for this group of patients who do have a residual AVM, what can we do? Typically, the volume that needs to be retreated is significantly smaller. And so as a result, the volume at the time of retreatment may allow us to even give a little bit higher dose than what we gave before. Sometimes it's a reflection of a target that was not completely covered the first time around, and there's a small remnant that remains and allows us to repeat the procedure, again leading to a total obliteration rate. That being the goal. There are other reasons, and we'll talk a little bit about that as we talk about the potential role for embolization in the management of AVMs. So after repeat procedures, then we see a similar type of curve, in the sense that by the time we get out to 3 to 4 years, and we can then document with angiography that the AVM is closed, we can see that, again, the 70 to 80% of the patients who had a second procedure will go on to complete obliteration. So that means that overall, we end up with approximately 90% chance of complete closure of the AVM with either 1 or 2 procedures. So why does embolization across the board, and all the reported studies over the recent years, show that prior embolization actually reduces the success of radiosurgery? There are a number of reasons that this can happen, especially in more recent years, when the type of embolic agent has moved from beads to IBCA, now using onyx. We see that there's a very large artifact that's delivered into the AVM, and that can make targeting of the residual volume for radiosurgery more difficult. And because onyx has a very significant cast as well as artifact on MRI scan, which we think is crucial for targeting in most patients, and if not MRI, then we use CTA. Then this significantly reduces our ability to fine-tune the target volume. In prior years, there was certainly a risk that previously embolized volumes, and those were excluded from the dose delivered by radiosurgery. Those can recanalize over time, leading to refilling of the AVM. To some extent, there may be a selection bias issue going on because many times only larger volume AVMs were selected for embolization, and therefore those patients may have been or received a lower dose. If we look at this particular study, which we published looking at the more than 3 years of follow-up, we could see that the curve of response over the course of time, which again is dose related, and the maximal marginal doses of 20 gray with some improvement even with higher doses are significantly reduced in patients who had embolization. And that means that these patients have much less success overall and have a higher remaining risk of hemorrhage because of incomplete obliteration of the AVM. Now, of course, patients with AVMs, especially with lobar AVMs, have additional risks related to their AVM. So we really looked at our own patients with lobar AVMs that are associated with seizures. And these patients often had a mean seizure frequency of at least 1 per month. And treatment of the AVM target, not the surrounding brain, but the target itself, which is the cause of the seizures in many patients, resulted in significant improvement in the seizure risk after obliteration of the AVM. In this case, 70% of our patients with seizures associated with lobar AVMs became seizure-free. Some patients were actually successfully weaned off of anti-epileptic drugs, but not everyone wants to take that chance. Because in many cultures, including the US, development of a seizure can be a significant impact on work and driving and things like that. So some patients simply choose to remain on long-term anticonvulsants. We typically use one criterion is that there have been no seizures for a period of at least 2 years. And then we do an EEG. And if the EEG shows no spike activity, then there's a fairly high probability that that patient could be weaned off of anticonvulsants with a low risk of developing recurrent seizures over the course of time. And typically, as the AVM actually regresses or shrinks over time, the benefit of seizure reduction continues to increase over the course of several years. The seizure type that was most responsive is major motor seizures, and patients with partial complex seizures were not as successful in complete seizure control. Now, many patients also present with AVMs with an MRI scan that was done as part of a headache evaluation. And in fact, certain types of headache, especially migraine, are almost always present in patients with AVMs in the occipital and temporal lobes. In fact, my own belief is that any patient with classic migraine and progressive headaches needs to have an MRI scan just to exclude an AVM in their brain. But the one that is most likely associated with headaches are patients in the occipitotemporal region and typically a visual aura as part of their migraine. And what we found in our study in that group of patients with migraine related to their AVM, there's a very high chance of improvement, but not complete complete recovery from their headache problem as time goes along and as the AVM responds. Now, like everything we do, there's no zero risk environment. And the goal that we're trying to do, of course, is to get rid of a structural target in the brain and restrict side effects based on the anatomic location of the AVM. And certainly we can see changes on the MRI scan over the time. MRI is very good at predicting both reactive changes or adverse radiation effects. It's also good at predicting closure of the AVM. And at the target volume, when we give intravenous paramagnetic contrast, we will see a pickup of this with a reactive change surrounding it, which on T2 signal we call edema, although in various animal experiments, we can see that in some cases this change that we see as T2 signal may in fact be a temporary astrocytosis and not necessarily just water development there or edema. But this gradually goes away over the course of time with serial MRI scan. And again, as I mentioned, in using MRI scan to try to predict closure or obliteration, we want to use both contrast enhanced as well as T2 studies because the T2 studies are actually more reliable in predicting that the AVM is closed because we lose the signals from the flow voids of the T2, whereas contrast enhancement may persist for years after the completion of obliteration of this. So overall, in our experience, and this is 800 patients, there's a 5.7% risk of an adverse radiation effect. Not all of this requires treatment. Certainly such changes noted in less critically important areas of the brain, such as the frontal lobe, may not be associated with any symptoms. And in that case, we don't really need to intervene or treat. If, however, a patient does develop headache or focal neurological findings, we typically use a short course of oral corticosteroids. But it's important that it be short. We never go more than 3 weeks because of the long-term side effects of corticosteroids, especially at even moderate doses. And at the end of 3 weeks, we get them off of that. If they still have some symptoms, we typically treat them with a combination of vitamin E and pentoxyphylline, 400 milligrams, 400 international units of vitamin E, twice a day for a period of 90 days. And at the end of 90 days, we take them off of that. And for most patients, the symptoms have improved or resolved. But we really don't need to do anything much more than that in most patients. In very refractive cases, and after we know that there has been complete obliteration of the AVM confirmed by angiography, we might be willing at that time to use a short course of low-dose bevacizumab as an anti-VEGF agent, which is often very effective, but I would be reluctant to use it until I found that the AVM was in fact obliterated. So how do we predict the risks of a adverse radiation effect over time? So many years ago, John Flickinger, working in our group, looked at the volume of brain and target that is we're going to receive in a single dose, 12 gray or greater. And that, of course, would include the target and the fall off area outside of the target. And that 12 gray volume is relatively predictive of the risks of a radiation related complication over the course of time. But as you might expect, it's all related to real estate. And when we put together all the patients in various groups, the critical areas in which there is a statistically significant difference in risk, and again, you would expect this to some degree related to the importance of the real estate, brainstem being the highest risk rate, the thalamus next, and with its relationship to the internal capsule, because swelling or reactive changes that affect internal capsule are going to lead to contralateral motor symptoms. And therefore, those patients are going to become symptomatic and come back to medical attention. And then lobar locations of the brain have a much lower risk. So what we can do when we're doing a plan of treatment is we calculate the volume of the AVM. Of course, prior to radiosurgery, we can use a simple calculation of the X, Y, Z dimensions divided by 2 as a sort of estimate of oblate spheroid. But during the time of the planning, we get much more accurate volume by combining not only the angiography and the MRI scan for targeting, and we can also look at the volume that's going to receive 12 gray or greater, and that gives a much higher likelihood of detecting both symptomatic changes as seen in the upper graph. On the right graph, we can see the chances of permanent or irreversible adverse radiation effects. And the 12 gray volume is a very important way to look at this. So that helps us to, but not only predict, but also to warn patients or families about this, and that risk may be varied based on the type of AVM, location of the AVM, and the goal, which is of course to get rid of the AVM. Now, in a selected group of patients over the course of time, and this largely means patients whose AVMs are at least greater than 10 cc's in volume or 10 milliliters in volume, typically always more than 15 cc's. Those are patients who we prospectively volumetrically stage with 2 procedures separated by about 3 months. And what we do on the first procedure is we do MRI and angiography, and then we determine the entire volume. We do a plan as if we were going to treat the entire AVM, and then we start subtracting out part of the dose in order till we get to about half the volume, and we treat that volume first, and 3 months later the patient returns and we treat the remaining half of the volume with the same margin dose so that we hope to be able to increase the rate of obliteration response. And these are patients, especially with deep-seated AVMs that have presented with a hemorrhage risk or a new neurological problem that's developed. And in this experience, almost half the patients had prior embolization because that's the gateway through which they came. Often they come through another center that is decided to treat the AVM with partial embolization to try to reduce the risk of a hemorrhage. But we have found in our experience that partial embolization, if anything, may increase the risk of hemorrhage and certainly does not do anything to decrease the risk of time. So in a case such as this, we define this using first MRI scan, and then we're going to treat the inferior component. There's no exact reason why you treat in one stage the inferior component, although often there's deep supply of that AVM, and then we're going to treat the second component 3 months later. And in this patient with the inferior component in the upper angiographic panels, and then at the end of 4 years, angiographically, it's cured. And this 20-year-old patient with this large left frontal AVM is simply too big to treat effectively with a single dose, because we would have to reduce the dose dramatically in order to achieve response. And at the end of time, we see angiographically the AVM is gone. We can see persistent reactive changes in the frontal lobe here and persistent contrast enhancement. And it's very important to realize that that doesn't mean that the AVM is not gone. The T2 study is better and it shows no flow voids because that contrast will persist. And when we looked at the larger series to determine what we could do to increase the chances of success, simply treating this at a certain dose at the margin, but not maximizing the percent volume of the AVM that's going to receive at least 20 gray, we had much less success than in those patients in which we prospectively increase the percent volume that is going to receive at least 63% gray, leading to obliteration rates in the 70 to 75% range. So we can do this with the planning systems by doing an initial plan. In this case, the upper panels show a plan in which the 50% isodose is getting 17 gray at the yellow line. But by putting multiple additional fields of radiation within the target volume, we can gracefully expand the percent volume of the AVM that's going to receive at least 20 gray from 56% to 71%, and therefore predict a much higher chance of complete success in the staging of this large occipitotemporal AVM. Pediatric AVMs, in my view, are a real challenge because in children, AVMs can continue to grow and form. An AVM such as this, which is a fine a network of AVM, it's very hard to sort out what represents shunt versus what represents angiopathic change, which is not really needed to be part of the target and will go away once the entire shunt of the AVM disappears. But this larger volume AVM in a critical location of the brain was treated with multiple procedures to try to lead to complete obliteration of the AVM, only to find over time that the AVM continued to expand. However, ultimately, this made it possible, especially after another bleeding event now associated with an aneurysm detection, to be successfully removed with a good outcome with this child. And that can be something where we have to use all the strategies that we have at hand in order to try to improve the overall outcome of success rate or obliteration. It had always been my thought that children, brains being younger and blood vessels being younger, would respond faster to obliteration and perhaps more completely than adults. But in this study from our consortium, the International Radiosurgery Research Foundation, using a matched cohort trial of children versus patients older than 18 years of age, we found no difference in the obliteration rates over the course of time. Of course, it can be used for AVMs located everywhere in the brain. And of course, we use it for dural vascular malformations as well. But in this case, we have found in our experience that the outcomes were not related to whether supratentorial or in the infratentorial region. The outcomes and expectations of closure were the same if you properly targeted the AVM. Over the years, we've looked at other particular risk factors that may influence the risk of subsequent hemorrhage in a patient with an AVM. There are patients who have a flow-related aneurysm proximal to the AVM, and with increasing resolution of angiography, more commonly we can perhaps see small intranidal aneurysms, whether these represent venous ectasias with rapid shunting or fistulas within an AVM or true arterial aneurysms. Is very hard to sort out sometimes. These add to risk related to the patient for their AVM. We'll talk a little bit more about what is the effect or possible impact of patients with variceal venous drainage from an AVM, which usually indicates a very high flow or a more concerned partial outlet obstruction of the draining vein, which is probably a major risk for hemorrhage. So in a patient such as this with a proximal aneurysm, in earlier years, we were gratified to see that the flow-related aneurysm went away when the AVM went away. I think nowadays, with increasing ability to do things with endovascular techniques, we might think about treating this aneurysm as well. The problem is in such patients, for example, if you're going to use stent coil for this type of aneurysm, the patient may need to be on an antiplatelet agent, and an antiplatelet agent in the face of an AVM is, in my view, additional risk. But for other patients, we may want to actually be more aggressive in terms of treatment of the aneurysm by either clipping or coiling is deemed appropriate by your team. We recently looked at whether a patient with variceal venous drainage, which again may be a concern related to venous outflow obstruction, has a effect on the obliteration of the AVM. And we were happy in this series of patients that varices did not decrease the success rate related to obliteration rates. They were the same with or without varix. But a more concern was there a risk that the patients with variceal venous drainage, possibly representing venous outflow obstruction and therefore an increased hemorrhage risk, would those patients have a higher bleeding risk in the latency or waiting phase after radiosurgery? And in this patient group where we looked at this, actually, the probability of a hemorrhage afterwards was no greater between the patients who had such variceal venous drainage compared to those who did not. Now, there are other late complications that occur and why follow-up imaging is important in AVM patients over the course of years. Most series have shown this risk of late cyst development of 1.5 to 3% of reported AVMs. I am finding this a little bit more common in patients who had prior embolization and also a little bit more common in patients who had prior hemorrhage. That's because iron pigment left in the region of the AVM probably represents a radiation sensitizer and may increase this risk. Generally, these require surgical fenestration when they are found as they continue to grow over the course of time. But usually simple fenestration is enough to solve the problem. So this risk of this happening is relatively low, but the general rate is 1.5 to 3% as looking at this combined series published from the UVA experience. Over the years, one other late complication has been detected. That is the risk of developing a chronic encapsulated expanding hematoma of an AVM that is obliterated. In the case example here, this large AVM was successfully obliterated in the temporal lobe. The patient developed two late complications, one cyst formation and one a gradually expanding hemorrhagic in the mass in the temporal lobe, even though the angiogram shows nothing. And when these are removed surgically, and that's almost always what's needed, the craniotomy and surgical removal, that solves the problem. Pathologically, these are fibrotic tissue with no evidence of residual AVM. And we recently did a study looking at the tissue of these cases. We had 6 that were removed looking for evidence of expanded VEGF production, but we really couldn't document this. The usage of susceptibility weighted imaging has made recognition of these more common, and these will continue to grow related to micro rehemorrhage, neovascularity development, and over the course of time generally require surgical removal, which is curative. The overall risk of this problem in our surgical AVM series for Gamma Knife is 0.4%. Now, one of the questions concerns many people is, of course, the usage of radiation and what is the risk of developing a radiation-related complication, such as a malignancy in the brain associated with prior exposure to radiation. And in this study in Lancet, where data from multiple centers was put together, the overall risk of development was extremely low, not much different than the risk of development of a brain tumor over the course of years, but is 0.045% at 10 years. So what have we learned over the years from the usage of radiosurgery in the treatment of AVMs? First of all, obliteration is the goal, and the rate of success varies at 3 to 10 years. Part of that is related to the timing of when you can document using angiography complete closure of the AVM. And that success rate is, we know, related to dose and volume. If, however, we give the dose volume in the frontal lobe or in the thalamus, as long as we give this, we will have 18 gray, hopefully over more than 20 gray, getting more than 63% of the AVM. We can improve the obliteration results. However, even in the best case scenario, approximately 10, depending on dose delivered to stage 1, will about 10 to 35% may require a second procedure. And the success rate again is up to 70% of those particular patients will go on to a complete obliteration. If we're going to just select large volumes because of no other effective option for the management of their AVM, we will have to stage it. Embolization is a procedure that may be very beneficial prior to a surgical removal, because it may be able to reduce the risk of the surgical procedure, especially by getting rid of deep feeders. But prior to radiosurgery, it worsens outcomes. And if you're going to use radiosurgery, you still have to treat the same volume with or without embolization. And embolization has a risk of 1% mortality and 10% morbidity per embolization. So we would discourage its use prior to the use having radiosurgery. Patients and families need to be aware about the late risks of surgical complications, the requirement that aneurysms may require additional management. And we know that hemorrhage rates effectively decline after radiosurgery, but never go to zero because of these other risks that remain, especially if we didn't completely confirm closure. And during the time of waiting after radiosurgery, we don't increase the risks of a hemorrhagic event occurring in that group of patients. So thank you very much for your attention. And I think there's going to be a question and answer period for a period of time. And thanks for participating in this important educational activity. This is a picture of our team being 32 years in the making here. And at your own center, we would always encourage a team concept. Thank you.
Thank you very much for such a wonderful lecture, Dr. Lunsford. I'm sure all the audience has learned from your robust experience. Right now, we have a few questions from the public. I'm going to read them to you. So, what is your opinion about CyberKnife and arterial malformation treatment?
Well, there are many technologies that are used for radiosurgery. This includes linear accelerator-based technologies such as CyberKnife and other manufacturers as well that use Linux. I think the important thing to understand is that maybe the technology is not as important as the accuracy of the planning and the dose that is needed to achieve obliteration. I think it's very important to understand that the goal is to get rid of it. Short of getting rid of it, we really don't change the natural history of a hemorrhage or a stroke. And therefore, since we know the dose and percent dose of the AVM that's going to get at least 20 gray is important, the technology that you're using needs to do that. But secondly, the important aspect is to restrict dose outside of the target. And therefore, the technology you use must have very sharp fall off on the edge of the target so that the surrounding brain receives a very low dose. And therefore, we can look at the 12 gray dose, which includes the target and the surrounding brain, as a predictor of risks. So in our experience, Gamma knife provides the best means to be able to restrict dose to the target and reduce dose to surrounding brain. But those are important features in terms of not only success, but also reduction in complication risk.
Thank you, Professor. Do you always wait to the AVM to bleed or be symptomatic to treat them with radiosurgery, or there's an additional role of the radiosurgery on ruptured AVMs?
Yes, thank you for the question. I mean, there's been a lot of confusion that has occurred more recent years based on the Aruba study, which unfortunately was a very poorly designed study. Which simply showed that if you do early intervention, primarily using embolization for treatment of AVMs, that those patients actually probably have higher bleeding or death rate than patients who had nothing done. And this led, unfortunately, a large group of neurologists who often see patients across the world to conclude that nothing should be done for AVMs that have not bled. And this is completely, in my view, false. The risk of an AVM is cumulative over the course of time, whether it's as low as 1% or as high as 4 to 5% per year. The risk of an AVM is partly related, of course, to how long you live. But there are other angiographic features which help to predict the risk of a hemorrhage as well. Furthermore, this is a lifetime risk. It's not a risk of 1 to 2 to 5 years, as even the long-term Aruba outcome data looked at. It's a lifetime risk for a patient, and a 50% risk of major neurological deficit or death occurs from the initial bleed. So in my view, intervention is important in almost all AVMs. And the success rate, of course, can be increased in smaller volume AVMs. So the only ones whom we would clearly consider observation of are that group of patients with very large AVMs, and we're looking at the risk and benefit of intervention. We cannot demonstrate in a, let's say, Spetzler-Martin grade 5 AVM that intervention early provides a risk-benefit ratio that's acceptable. Once that's patient's bled, however, that risk may favor doing a radiosurgery in a staged method to try to reduce future bleeding risks.
Thank you, Professor. Is there a role for radiosurgery to treat diffuse AVMs?
Diffuse AVMs are, in fact, problematic in many ways. First of all, they're more common in children, which can mean that they grow over time. Secondly, they're harder to target. And thirdly, it's harder to sort out what represents the shunt of the AVM, which is what we're aiming at, compared to patients who have dilated arteriolar bed or angiopathic change surrounding the shunt, which often will normalize once the actual AVM target is completely obliterated over time. But there's no data that shows that treatment or observation, that observation is the right thing to do, because these have the same risk, in fact, probably a greater risk of hemorrhage than do patients who actually have a very tight, sharp nidus. So the answer is yes, we treat such AVMs. It just becomes more difficult to sort out the proper target.
Thank you, Professor. You showed a lot of results regarding the AVMs in pediatric population, but there's a lot of controversies around the radiation on this population. Do you prefer radiosurgery over surgery in pediatrics?
We recently published in the Journal of Neurosurgery Pediatrics a article summarizing our experience in pediatric AVMs, including both surgical embolization and radiosurgical procedures. And if you look at that paper, the first author was Mike McDowell. The best outcomes across the board in this group of patients were those patients who got radiosurgery, not the patients who received surgery or embolization, or a combination of that. And if you look at across the years at our pediatric hospital, the number one procedure that was performed was, in fact, radiosurgery, and those patients had the best outcomes. So there's no question in my mind that, and the results are the same as we've shown on one of the slides in terms of success rate. These patients should be considered to have radiosurgery as a primary option, as at least in our experience, those patients are the ones who had the best outcomes.
Perfect. So what is the age of in pediatric do you recommend using radiosurgery for this treatment in the AVMs?
Well, one of the issues, of course, in very young children is that the body is much smaller. And while the targeting using the gamma knife delivers high dose to the target within the brain, Other organs and body parts are, of course, closer to their sources in a very small body compared to an adult. We have not seen any risks of subsequent other endocrine problems such as thyroid or other things like that developing in these patients. And the radiation that would be delivered to certain organs such as gonadal organs, thyroid, things like that is all scattered radiation. It's a very low dose. But that's one of the things that has to be considered. The other, of course, is what are the other options? The youngest child we treated was 3 years of age. That patient had multiple hemorrhages from a vasoganglionic AVM. And had multiple embolizations prior to this to try to reduce the hemorrhage risk. But as a general concept, most patients in the pediatric group are being diagnosed after a bleed. That is, that's how they were found. And of course, more often AVMs in children are in deep locations or basal ganglia or thalamus or posterior fossa. And these patients have a very high risk of hemorrhage ready to rupture into the ventricular system. Then, of course, you need to do something. But I would also say that I think that children who give a strong history of having vascular headache or migraine, all of these patients should have a simple, short, long TR-T2 study of their whole head and make sure they don't have an AVM. Consider treatment early on to try to reduce the lifetime risks of these patients having a hemorrhage, death, or stroke.
Thank you, Professor. Francisco Perez from Bogota writes, thank you, doctor. In a patient with several intranidus aneurysm, what should be the target dose?
So there are certain patients, and sometimes it comes through what gateway they came diagnosed with intranidal aneurysms, and those patients have already undergone embolization to try to get rid of the aneurysm, knowing that they can't completely get rid of the AVM. So it's very important that those patients go on to additional treatment with radiosurgery to try to get rid of the AVM. What we don't have good data on is that approach, that is selective embolization for patients with intranidal aneurysms. Does that actually reduce the risk of a hemorrhagic event in this, let's say, 3-year waiting phase after radiosurgery? So there's not very good data related to that. I think it's a reasonable hypothesis to maybe consider, but it also has to be put in the context of what's the risk of a hemorrhagic stroke related to the actually embolization procedure. Intranidal aneurysms will in fact be receiving the highest dose of radiation if they're buried within the AVM itself, and are very highly likely to obliterate, as does the entire AVM nidus.
Thank you, Professor. I have a personal question. As you recommend aneurysm associated with AVMs should be treated, what happens with the developmental venous anomalies? Do you treat it too?
Developmental venous anomalies, or DVH, in my view, have an extraordinarily low risk of any complication ever. Although some patients will also have associated cavernous malformations. Then in certain patients who have symptomatic cavernous malformations in deep-seated locations, we do use radiosurgery gamma knife effectively to treat those. However, developmental venous anomalies in most patients represent a sort of anatomic variant of blood leaving that area of the brain as opposed to the rest of the world. And they're very low flow, and they're having extraordinarily low risk of ever having a hemorrhagic complication. And in most patients should be simply told, this is an incidental finding, it's irrelevant to your health, and don't do anything.
Thank you, doctor. Another question from the public. Humberto Madriñan from Bogota asks, is there a limit in size to treat the AVM with radiosurgery?
Yes, limited by size, but also limited by success. So in AVM smaller than 10 cc's, which we typically do in a single procedure, We can look at these success rates of 80 to 90% success with 1 or 2 procedures. In patients with much larger AVMs, the Spencer-Martin grade 4 or grade 5 AVMs, then we have to divide this into 2 sessions. And there are a few patients who we have prospectively done this into 3 stages because of the overall volume of the AVM in a patient with no other really good option. Most of these patients have large AVMs, critical locations, the thalamus, the occipital-temporal lobe, where surgical removal is going to have a major risk of a new neurologic deficit. But there are some patients, every once in a while, I'll be sent a patient who looks like almost the entire hemisphere is an AVM. We can't treat these types of patients. There are simply some patients where techniques such as focused radiation simply has not the sufficient risk and benefit ratio to treat it. We do not have any data that partial treatment reduces the risks of the AVM obliteration or stroke. The goal is to get rid of it, and that seems to be true regardless of what procedure that we use, whether it's embolization surgery or radiosurgery. The goal is to get rid of it, and the AVMs that are this very large size are simply too big to effectively target without high risk.
You showed in your presentation that the previously embolized AVMs have less obliteration rates with the time. Neither in the type grade 4 and 5 AVMs do you consider pre-embolization?
Correct. We generally discourage using embolization except for perhaps a very specific circumstance where the patient has a well-recognized intranidal aneurysm where we think that selective embolization might be able to get rid of that. And as I said, that's a good hypothesis. There's not a lot of data to show that is effective in reducing hemorrhage rates. But since embolization does not change the target volume, and since there's no data that embolization reduces the risks of further hemorrhage, the goal, we think, still has to be complete obliteration of the AVM. So embolization, in our view, is a technique which is greatest value is in preparation for surgical removal of the AVM as a combined procedure, which enhances probably safety and the ability to completely resect the AVM. But the overall, as the Aruba study showed, the overall risk of embolization simply could not improve the overall risk of stroke, hemorrhage, or death, at least within the first 5 years afterwards. And similar for radiosurgery, since there's a latency interval, it's not like we do it and it's gone. We do it and it's 1 year, 2 years, 3 years, the success rate builds. During that time, we don't increase, but we don't get rid of the hemorrhage risk during the patient. But after it's gone, then we can show significant risk of subsequent hemorrhage in these patients. So in the observational versus doing radiosurgery, if we look at when the curves cross, they probably cross around 6 to 7 years. And at that point, the patient's AVM is gone and the risk of hemorrhage goes close to 0 compared to patients who continue to have a lifetime risk of an AVM that's never been treated. But again, this timing of the curve of risk benefit is probably over 6 to 7 years.
Thank you, Professor. Another question. Dr. Julian Andraus asks, thank you, Dr. Lunsford, for an amazing lecture. Is there an area in which you will be cautious or even against radiosurgery due to potential risks?
Yeah, as almost anything that we do, we have to balance our own knowledge about the risk benefits, and we have to make sure that the patient and family are educated as much as possible. As we've shown, the risks of complication, both short-term and long-term, that is permanent neurologic deficits, is much higher in the patients with brainstem, that is midbrain, pons, medulla AVMs, and thalamic and basal ganglia AVMs compared to lobar AVMs. That's because of the real estate. When you're dealing with an area of the brain where there's a lot of important neurologic pathways, especially the internal capsule, which of course is easily recognized as a deficit because the patients become weak or hemiparetic opposite, then these represent the special cases where you have to think about this. But if we look at the overall balance and the success rate of this, even if you have a 10 to 15% complication rate in a deep-seated AVM over time, that is still better than the projected 50% hemorrhage death rate in a patient who's going to live for a long period of time.
Thank you, Professor. George Towers from Bogota asks, how do you consult patients during the interval between C and obliteration?
So our typical follow-up period is an MRI scan at 6 months. And generally at 6 months, we don't see a lot of change, but sometimes patients and families are very, well, what's going on? And then annually, 1, 2, and 3 years. If at the end of 3 years, the MRI scan shows no flow voids, then if we do the angiogram at that point, we'll have a 90% chance that we will see AVM obliteration. There's a 5% chance perhaps that we will see only an early draining vein on the angiogram. And we used to think that that means there's still flow because the vein's filling. But in that group of patients, that has never been associated with a risk of subsequent hemorrhage. And with the repeat angiography 6 months to a year later, that early draining vein is no longer seen. So it's sort of a moment in time. And I tell patients that we can use MRI scan to show the progression to obliteration that we're looking for. But since we're not going to consider retreatment until at least 3 years have passed, and then only if we see evidence that they're still filling on the angiogram, we don't repeat the angiogram early unless there's a problem that the patient has. We wait until 3 years. That's going to then be a decision point about if there is still AVM. We're going to recommend retreatment to get cure. During the time we're waiting, the patients have no increased risk of having a hemorrhage from their AVM. Radiosurgery doesn't increase the risk, but we don't have evidence that it's eliminated the risk until we know that the AVM is gone. On the other hand, in maybe half the patients with smaller AVMs receiving appropriate dose, it may be gone at the end of 1 year. So some are cured as early as 1 year. Whereas others may take up to 3 years. So if we get 70% of the AVMs are cured by 2 years, and maybe 80 to 85% of the patients are cured by 3 years, then there is a risk remaining of a stroke during that phase until the time comes that it's gone. But we're not increasing the risk by treatment. That's opposed, for example, in my view, to embolization, where most of the data suggests that each embolization has a 1% risk, maybe of a stroke or a serious complication, and maybe up to 10% chance per embolization. And those risks are much higher than what we see in radiosurgery.
Thank you, Professor. Previously, you talked about some considerations you have to take regarding the location of the AVMs, for example, in brainstem. But you don't consider there's an absolute contraindication for this treatment?
Well, volume, I think, is one, as we talked about. So very large volume AVMs, maybe the success rate is not good enough to warrant the risk rate. But for AVMs located in critical areas of the brain, if we look at the entire spectrum of AVMs all over that brain, and there's a 50% risk of lifetime death or disability from the AVM, a 1% death rate per year. I think there's fairly good evidence that intervention in these patients is appropriate. And even if it's located in the pons and the medulla, because if those patients have a hemorrhage, the neurologic outcome is going to be extremely poor. So yes, I think that almost regardless of location, intervention is appropriate as long as the patient family knows that the goal is to get rid of it, and that may mean that more than one procedure is going to be needed to reach the goal.
Thank you, Professor. We have another question from the public. After hemorrhage, how long you should wait to give radiosurgery to an AVM?
Yes, that's a good question, because I don't know that there's a great answer, but we're concerned that in patients who have a clot compressing the AVM, that early treatment may run the risk that you would undertreat the AVM, because as the blood clot gradually resorbs, the pressure goes off and the AVM fills more completely. So there's not a great guideline related to this. We use two things. One, the status of the neurological patient. That is, we would want to wait until the patient has recovered to some degree neurologically. It, of course, will depend on where the clot is. Secondly, we typically would wait about 6 weeks or so after the hemorrhage. Now, if it's subarachnoid hemorrhage, that's different. But if it's an intracerebral hematoma, we would wait probably 6 to 8 weeks until the patient's neurologically stable and some of the clot has begun to reabsorb a little bit. And we would use the MRI scan again to monitor that progress in the waiting phase before we do the gamma knife procedure.
Thank you, Professor. Last question from the public. Sang Saiyeo asks, in a patient with an unruptured Spencer-Martin grade 1 or 2 AVM, would you recommend them to go for open surgical excision rather than gamma knife radiosurgery?
Yeah, so it's an important question. I think that first of all, let's start out with, should they have something done? And in my view, the evidence presented by Aruba is incorrect and led to false conclusions. And the answer in my view is yes. Almost always these patients should have something done before some catastrophic event happens. Secondly, which option to use? But there are lots of issues here. It relates to location. Theoretically, a small volume Spencer-Martin 1 AVM in a less critical area of the brain in a center with a lot of microsurgical experience, the patient has a very high expectation of a good outcome in a center of excellence. You know, you can't get rid of risks completely. There's risks of doing a craniotomy and wound infection and things like that, but those risks are really relatively low. And in theory, you took the AVM out, but you've also got to document that you took it out. It's gone. If it's not gone, then you really didn't accomplish anything. So you have to balance that out against the risks that the success rate for such a small AVM in a non-critical location with radiosurgery are also around 90% with a single procedure, but it may take 1 to 3 years to achieve that result, and the patient during that interval of time still remains at risk. There's a balance. There's not a good equation to be able to calculate that out. And sometimes it comes down to personal choice. But if patients are going to have surgery, you have to realize that the data that's been presented related to high level outcomes have come from centers that have published their experience with, and they've had a lot of experience. That's not the same as a center where they see 1 AVM every 2 years or something else like that. I think there should be some referral, some centralization of care for these types of things at a center where there's a team of people that can provide the best advice.
On behalf of CIEN, Dr. Lunford, I would like to thank you again. It has been a wonderful lecture. We are really grateful and honored for your participation in the 2021 IWBNC.
Thank you very much. It's a pleasure to participate, and best wishes.
Thank you. For all the audience, keep in mind this lecture will be available on our website starting next week. In a few minutes, we will have Dr. Rod J. Oskoyan doing his lecture, Advanced Approaches to the Spine. To get the link for this upcoming conference, please follow the link pin on the chat screen or check the program schedule on our website, signhouse.com. Thank you.